Hi, everybody. Welcome back to the Autoimmune Summit. Today we have the fabulous Dr. Jeffrey Bland, who is actually the father of functional medicine. This is such an honor to have him here today. He, in 1991, was the co-founder of the Institute of Functional Medicine, where I was trained, and many of our speakers have been trained or are also faculty members. He's now the founder and director of the Personalized Lifestyle Medicine Institute. He's also been a researcher at the Linus Pauling Institute and has written hundreds of articles and multiple books, and recently came out with the Disease Delusion. If you haven't picked it up, please pick up a copy. Today, we're obviously going to be talking about autoimmunity, and the title of his talk is Why Autoimmune Diseases Are Not a Result of Being Allergic to Yourself and What You Can Do About Them. Welcome, Dr. Bland.
Well, my pleasure to be here. Thank you so much, and what a treat, and what a great topic to spend a few moments talking about.
Well, and you are joining us from the Puget Sound, it looks like, out there in Seattle. It's a little fuzzy because it's so bright and sunny, which seems to be an awkward thing or an oxymoron for Seattle.
Yeah, it's pretty amazing. Our offices are like a little bit like a fishbowl because we have windows all the way around, and today is just one of those 80-degree days, blue sky. We can see Puget Sound out one side and Lake Washing out the other, and the Cascade Mountains and Mount Baker with snow on it, and Mount Rainier the other direction. So it's God smiling on us today.
You might not know, I lived in Seattle for a year, actually. I did all my post-bac pre-med prerequisites out at UW. So I am familiar with the view that you're talking about, and know that it's uncommon to see it except for maybe in July and August, are the brief windows that you get to see those. Well, let's get started. So, you're talking about this idea, nobody's really brought this up yet throughout the summit about, autoimmune diseases, that anybody could even potentially think that that's actually a result of an allergy. So tell us how autoimmune diseases are not actually being allergic to yourself.
Yeah, I'd like to, if I could, maybe step back just a step so we can kind of get a running start to that question, because I think that's a really pivotal question. And it's a very controversial question, by the way, because in the field of rheumatology, as you well know, talking to rheumatologists, much of what we're going to be talking about, or what I will be saying, would be considered to be maybe controversial, maybe open for significant discussion, maybe theoretical. But I believe as the literature and the science has evolved, particularly the last 4 or 5 years, that what we're going to talk about is not just conjecture. I think it's fact and reality. But it's not necessarily that which all rheumatologists today would stand up and say, yes, I agree with. So why is that? And what's the difference of opinion? So this starts a little bit with the construct that autoimmune diseases were diagnosed in part as a consequence not only of symptoms where people presented with swollen joints and with painful joints and muscles and so forth, and kidney problems, but also was a consequence of an elevation in their blood of certain proteins that are called antibodies. And antibodies are proteins our immune system makes in response to a perceived foreigner. So this could be like an infection or a chemical that's a foreign chemical. And when they started analyzing these antibodies for their origin, they found that these antibodies looked like they were antibodies against the tissues of the body, like antibodies against the material that we're made up of, like our proteins and our structural materials that actually cause us to have function. And so because these were native proteins that these antibodies were being produced to, the assumption was that autoimmune disease was a little bit like becoming allergic to yourself, because you're making these reactive proteins from your immune system that are going out to seek and destroy, but they're seeking and destroying the materials that we're actually made up of and causing degeneration. So the dominant theme in the field of rheumatology for many decades is that we become progressively kind of intolerant to ourselves, and our immune system starts to see us as a foreigner. And the other dominant theme is that these diseases of becoming intolerant to ourselves, these so-called 80 different members of the family of autoimmune disease that have names like rheumatoid arthritis and systemic lupus erythematosus and myasthenia gravis and multiple sclerosis and Crohn's disease, that family, thyroiditis, autoimmune thyroiditis, that family of 80 plus different diseases are were historically thought to be genetically related. So when people say, well, why did I get these? The common answer was, well, it's in your family because you had an aunt that had MS, or you had an uncle that had RA, or you had a mother that had myasthenia gravis. And as a consequence, the concept of becoming allergic to ourselves or intolerant to ourselves tied to our genes led to what I believe is a concept of disease determinism. The field was kind of, and still is, I think, painted with this concept that when a patient comes in with an autoimmune disease, that woe is them, they had bad genes that encoded for this condition, there's nothing they can do about it, their body's going to become more and more intolerant to themselves, and they're going to have more and more war within, and the best we can do then is to fight back by defusing the body's immune system, because if your immune system thinks that you're a foreigner, then you either have to get rid of your foreigner or you have to get rid of your immune system. And the medicines that we use are those that get rid of the immune system. I mean, I'm exaggerating slightly to make a point, but they're medicines specifically designed to deactivate the immune system. Now that is a pretty good strategy at one level in that it will reduce the collateral damage of the immune system attacking the body, but the other side of the coin is that immune system is there to do a lot of good for us, and it defends us against infection and all sorts of things, including transformed cells in our body that might be potentially cancerous. So when you start diffusing your immune system, it's not without some potential consequences. So there are many adverse side effects to the drugs that are used for the treatment of these autoimmune diseases. And we get away, and I don't want to say we get away, but we tolerate that because that's the best we thought we could do. We tolerate it because, gee whiz, if we're becoming intolerant to ourselves and our immune system are attacking more and more our body, then the best we can do to reduce suffering is to pay the price of lowering the activity of the immune system and then putting up with the possibility of opportunistic infections and all the things that come with lowered immune function. However, the thing that now, and I say now, I mean the last 20 years, has started to be more seriously evaluated is, well, is it really true that we're allergic to ourselves? Are these antibodies that are being produced by our immune system really attacking our host tissues, in other words, the friendly things that we're made up of? Or are they attacking modified versions of our host tissues that are really foreigners to our body? In other words, we thought they were friendly, but they actually have undergone subtle damage, which makes them appear to our immune system to be unfriendly. Now, this is a whole new thought, right?
This is like a very new thought.
So if you ask that question, and then you say, well, what evidence would there be that somehow our bodies have been, certain portions of our bodies have been made to be not exactly as they should be? They're somehow made into a foreign modification. Well, let's take the most classic, well-understood example. And that is when sugar in our blood is at high levels, it starts reacting with proteins. And when it does so, that chemical reaction produces what are called glycated proteins. And in diabetes, which is characterized by high sugars running around in our blood, occurs that the sugars react with blood proteins like hemoglobin to produce funny hemoglobin. We call that funny hemoglobin glycosylated hemoglobin, or hemoglobin A1C. And actually this is a specific substance that is used to diagnose and follow diabetes. If a person has diabetes, they have the level of this hemoglobin A1C or glycohemoglobin measured routinely to see if in fact they are out of balance with regard to their insulin management or their treatment. And so what happens when glucose reacts with hemoglobin? It forms a funny hemoglobin, and that funny hemoglobin doesn't react and doesn't look to the immune system like a normal hemoglobin. Well, that glucose in a diabetic is not just reacting with hemoglobin as one protein, it's reacting with all sorts of other proteins, including the most dominant protein that floats around in our blood called albumin. And so glucose reacts with albumin as well to form glycoalbumin. And glycoalbumin is a funny albumin. The immune system doesn't see it as a normal, friendly albumin. So what does the immune system do in people that have genetic, highly active immune systems? They say, oh, gee, there's funny albumin floating around the blood. I better form an antibody to that albumin to try to get rid of the foreigner. Now, that is what we might think of as reacting against ourselves or becoming intolerant to ourselves. But it's actually not intolerant to ourselves. It's intolerant to a modification of ourselves.
Right.
Now, let's take this to another example. There are certain drugs that are well known to increase the risk to autoimmune disease. And this is one of the side effects of these drugs. A physician who prescribes them has to follow in their patients very carefully, because often over time a patient will become intolerant to those drugs and will develop an autoimmune condition. Now, how does that happen? Why does suddenly the immune system become intolerant to the host because they're taking a drug? Well, when you look more closely, it turns out that these drugs initiate a reaction in the body, a chemical reaction that damages certain proteins and certain materials in the body that makes them no longer the same as they were as the friendly tissues. They become foreign tissues within the body. So those drugs actually modify the function of the body in such a way as to create new kinds of funny molecules within tissues. And what happens? The immune system says, oh, foreigner on board, I better do my work. Now, where am I going with this? What's this whole story about? The story is really taking us to really a big aha, saying maybe we don't become allergic to ourselves. What is happening in patients with autoimmune disease is they become more and more intolerant. Their immune system becomes more intolerant to foreign substances that are building up in their body over time. And the people that are most likely to get autoimmune disorders are the yellow canaries, who have the most sensitive immune systems in their genetics to these foreign molecules. So it's not like you have the genes to autoimmune disease. You have the genes of reaction of your immune system to foreigners. And the more foreigners you have, if you have those genes, the more reaction you will have. So it's not that somehow there's a weakness in a person's genes if they get RA. It might be that their immune system is very, very sensitive and hypersensitive to foreigners. So it's almost like it's too good, and it overreacts to an environment that's creating these funny molecules. Now, why I say that is I think with diseases, there's an often kind of adverse, unexpected fallout to the patient, that they feel flawed, or they feel imperfect, or they feel they got the bad luck of the draw, that somehow their genetics, which they didn't even fill out an application for, just got stuck on them, and they got the RA genes, the rheumatoid arthritis genes, and there's nothing they can do about it. And what we're really starting to see is this is not an example of people having flawed genes. What people have are unique genes that are unique in the way they respond to their environment. And therefore, they might even have in their history, of their family history, if they went back, 10, 15, 20, 100 generations, that sensitivity that they have that produces RA in them might have been advantageous to a preceding generation of their ancestors, because maybe it gave them protection against a disease that killed everybody else, but they had a very highly sensitive immune system that allowed them to survive through a flu or something of that nature. So I think that we often stigmatize people by saying, oh, gee whiz, you've got this thing, you can't get out from under it, it was a bad luck of the draw in your genes, and your heritage just made you a person that's going to get this disease. And now what we're saying is, no, it's really the environment in which you have been living that has created some injury to your host tissue that your unique immune system, based on your genetic uniqueness, is responding to. So rather than just uncoupling your immune system with a drug, let's go and try to find out what it is that's damaging your tissues, that's producing these foreigners, and correct that. And then your immune system won't have to overwork and produce these antibodies that react and produce these adverse effects. So now that's a theoretical model. The question is, going from theory to practice, does this really work out? Do patients with autoimmune disease, if you use this model before you jump in and start using immunosuppressive drugs with them, does it really work? And my experience over the last 25 years is it works incredibly well.
Yes.
And so that's my answer, a long-winded answer to your very profound question.
Well, I have several more questions to that question, which is, I feel like when I was little, and of course I'm now in this world, and I have autoimmune, and I have sort of branded myself that many people with autoimmunity come to see me. So I obviously see tons and tons of it, but it does seem, and we do know, that the incidence has risen significantly over the years. And kind of what I was thinking about, and we'll get into some the term epigenetics and what really that is. But something that I literally just thought of as you were saying all that is, we know epigenetics and that it's not just your genes, but sort of all these environmental factors, which I'll have you go into, influence them. But I'm wondering if back, our grandparents' day, we didn't have as many insults in the environment. So is it really that maybe it was more genetically based back then because there weren't as many environmental factors to create that epigenetic shift? Or what really is this rise? So I guess my question to you is, how much do genes play an influence? Tell us about epigenetics and what really is this rise about?
Yeah, I think that's a very good point. The first point I think that we know for sure is that there is not a single one of the autoimmune diseases that are solely what's called a monogenetic disease. In other words, caused by one gene. And even things like celiac disease, where we think of polymorphisms or mutations to certain genes like HLA, DQ5, and DQ8, where people say, well, those genetic characteristics give rise to celiac disease. Even in those cases, the penetration of those genetics into the phenotype, meaning how they would express the disease called celiac disease, is varied significantly based upon many other genes and how they're responding. So I want to make the point that there is no autoimmune disease that has ever been found to be monogenetic, meaning caused by a single gene characteristic.
And aren't we also seeing, are there now case reports of people with celiac that also do not have the gene? So the whole other end of the spectrum is that we're now seeing autoimmunity in people who don't even have that autoimmune gene.
That's exactly right. And actually, that's a very good example of what I'm trying to say, is that the genetics that relate to all these autoimmune diseases are very complex, and they are tied or linked to the conditions of these diseases, but they are not the cause of the disease. The cause of the disease is the factors in the environment, the etiological or triggering factors that open up the expression of these families of genes that give rise to these immunological problems. So we want to treat the cause, not the effect. In medicine, in arthritis, we've been treating the effect by uncoupling the immune system with these immunosuppressive drugs, which, like the corticosteroid drugs like prednisone, we know have serious adverse effects. They certainly will reduce the pain and inflammation of arthritis, but at very dear cost over a long period of time. So rather than that, we want to go upstream and say, what is it that's actually turning on these genes at the level that they're creating all of these antibodies that are then attacking our tissues and creating this collateral injury? And that, to me, is the model that is emerging out of this kind of functional medicine approach, because it started asking the questions, what are the various factors that could be contributing to the turning on of these genes that are overreacting and producing these injuries to our tissues? And when you start asking that, then the laundry list, which we'll probably be talking about, gets fairly long. There are many other things we would want to ask the patient about their connection to the disease related to their lifestyle, their diet, their activity patterns, their stress patterns, occupation, environmental exposures, because those things may be the triggering factors that will prevent the need to uncouple and suppress the immune system with the drugs like the TNF alpha blocking agents, Remicade or Enbrel or whatever.
And so what are some of those, just speaking of, I guess, do you want to define what is epigenetics and then speak to some of the environmental factors that you've seen in your research that have led to autoimmunity or play a role in autoimmunity?
Yes, epigenetics, as you've spoken to and others will as well, is a term that refers to something above the genes themselves. We've always assumed that the genes were the kind of Rosetta Stone from which we were made. Everything within our genes would determine exactly who we are, how we would look, how we would act, what our health patterns would be. That's what I call Mendelian genetic determinism. It came out of the discoveries that Gregor Mendel made 200 years ago, when he found he could predict the colors of peas when they were crossed over the colors of the flowers. And there is certainly, I don't want to throw the baby out with the bathwater and say there's no such thing as Mendelian genetics. There certainly is. But that's only part of the story, because our genes are not all expressed simultaneously. If they were, we would be a mess. We have to recall that in every cell of our body is the genetic message to make every other cell and every other tissue of every other organ at every other age in our life. So if all that information in every cell was expressed simultaneously, we'd be a total mess. We'd be chaos. So our cells are selected for only expressing certain messages, depending on whether a skin cell or an eye cell or a liver cell or whatever. And the thing that regulates how our book of life, our genome, will be read is epigenetics. It's the message that's laid on top, or let's call it the read here or do not read here messages that are set on top of our genome that says you will only have access to reading these messages. Some of this will be X-rated, you can't get to them. If you're a skin cell, you're not going to be able to read the liver cell message. And so we've always known that these marks did occur on our genome, because it explains developmental biology, how we emerge as a complex organism from a single fertilized cell. But over time, what we started to recognize, and when I say we, I mean the scientists in the epigenetic field, is that there are some of these marks that are put on that are transient. In other words, they're put on and taken off based on environmental exposures. They're not just a natural consequence of development of the embryo in fetal development. They actually are reflective of certain environmental conditions, like what happens if a woman is pregnant in their first trimester and she is exposed to a famine, and so she is unable to get proper calories. It puts epigenetic marks on the genome of her fetus in such a way that 2 generations later, those daughters have increasing incidence of diabetes from their grandmothers that were in famine during the course of their early pregnancy. Now, this is a whole different concept of genetics, right? Which means that there are environmental operators that modulate or affect how our genes are expressed. Now, I think that this in and itself is a pretty powerful concept, but it's even more powerful when you consider that 2 generations later means that these marks had to be transgenerationally transferred. They had to be passed on to the next generation. So it didn't just affect only the people that had the exposure. It affected subsequent generations. Now, with that in mind, you start thinking of diseases or disorders that have come in very high prevalence very quickly. And you say, how does that happen? How do we start seeing all this autistic spectrum disorder condition? How do we see so much atopy in children, the asthma and allergies? What's going on? Well, this could be a consequence not of genetic changes, but of epigenetic changes, that marks that have been put on the genome, these environmental marks from diet, lifestyle, exposures, chemicals, and so forth, are creating a different pattern of expression of the immune system of children that then shows these diseases coming up in much greater prevalence. So epigenetics, to me, is a powerful it's back to the future. We've known about epigenetics for over 100 years as a concept, but it's now this concept that epigenetics could be changed during the course of living as a consequence of exposures, even most often, obviously, in youth. But it also has been found what are called metastable epialleles occur even in adults. In animals that are older, it's been found that exposure to an environmental like post-traumatic stress can put marks on the genome in an animal that modulates how their stress hormones are going to be secreted from then on. So when you start thinking of people that have been in trauma or in war or been violence or been rape, things that are very serious traumatic events, this can lead to an epigenetic mark that modulates how their body's system responds from then on. Now you say, is this a permanent affliction, or can you wipe them off and repair them? And it does appear that these marks are metastable, meaning they're not so secure in their attachment that they can't be taken off. But the more traumatic that they've been put on, probably the more difficult they are to take off. That's kind of the message that's emerging. But they do have the ability to be reversed. So when we talk about that, we talk about programs that really modify significantly a person's lifestyle, a person's diet, a person's behavior pattern, really deep therapeutic intervention. Can that epigenetically modify their outcome so that they can get rid of stuff that's accumulated over the course of living where they had all these marks of injury on their DNA? And the answer is yes, it appears that those can be modified. And that's really the frontier, what I call the new age of functional medicine, because if we can actually not just manage the condition of the moment, but we can roll back to a clean genome so that we can put friendly marks rather than hostile marks on our genes, that's really true medicine.
Right. So what are some of those environmental factors? I mean, I know you talk about them in your book, and I think probably most of those, can cross over into autoimmunity, because your book is really kind of talking about chronic disease. So what are ones, just in general, and then if there are any specific to autoimmunity that you know of?
Yes, I think that the one that has been probably most discussed in the literature are these polyphenolic chemicals. There's a lot of very good literature showing that things like phenol, which, as you probably know, is a solvent that's gotten into our environment from chemical industries, that phenol has a very strong propensity for reacting with DNA to form funny DNA. And it can induce in, again, genetically sensitive individuals autoimmune response. So in that case, we would say there are certain chemicals within the polynuclear aromatic hydrocarbon family, or let's call it just organic chemicals, that may in fact be inducers of autoimmune disease. We also know, as we mentioned earlier, that gluten in certain sensitive individuals can create epigenetic secondary marks that may not be leading to tropical sprue and traditional celiac disease, but an intolerance that manifests itself as systemic inflammation and autoimmunity. So gluten is another one. Another one would be toxic, let's call it high levels of exposure to various heavy metals, lead, mercury, and cadmium. Mercury being one that's been most studied. There are some people that have very extreme response in their immune system to mercury, and this has to do with dental amalgams and response that people might have to amalgams that has been even linked to things like MS in individuals. And when they have these amalgams removed, their MS symptoms go into remission and their autoantibodies go away. So the heavy metals, lead, mercury, cadmium, is certainly within that family. Arsenic is another, not heavy metal, but another toxic mineral that also has been associated with autoimmune responses. Then there's a whole class of, as I mentioned, drugs that particularly many of the anticonvulsive medications that have been found to have a very strong propensity towards inducing autoimmune reactions. Then we talk about individuals that are nutrient deprived and pick up damage to their DNA as a consequence of insufficient folate or vitamin B12 in their diet, so that they can't properly methylate, and that then leads their genome to be susceptible to genetic injury. Because one of the things that we know is that our book of life, our DNA, is tightly woven into this protective vault that's stronger than Fort Knox. That's the nucleosome, and the nucleosome requires proper methylation in order for the security of that vault. So if you don't have proper methylating nutrients like folic acid, B12, B6, betaine, that the integrity of the security of that vault can be compromised, and now foreign chemicals may be more readily able to have access. Another nutrient that we know is very important for regulating this immunological reaction is vitamin D, which has gotten a tremendous amount of play over the last several years, and proper vitamin D status helps to promote proper regulation of response to environmental substances. We know that anything that induces free radical oxidative injury to the cells, that could be radiation, that could be chemicals, that could be toxins, those things will create injury to DNA, which then induces antibodies to be produced against that DNA by our immune system. So if you start looking at agents that prevent oxidative injury, free radical oxidation of cells, that's another important part. We know rancid fats are another agent that can form what are called aldehydes, and these aldehydes can react with the epsilon amino groups of proteins to form shift bases that make some funny proteins, and that then induces an autoantibody reaction, an immunological reaction. So one has to again think about the consumption of rancid fats. So I think maybe that's a pretty good start of a laundry list. What we're really talking about are many variables that are out there. Chronic infections, there's another one, right? Probably we should put on the list, because chronic infection induces injury to tissues through immunological activation that then can induce autoantibodies. So getting rid of infections that may be chronic infections in the gut or in the nasal passages or in the mouth. I think we need to even consider, periodontal disease and oral infections as being another locus for potential activation of the immune system. So all of these would be on our laundry list of you as a functional medicine provider when you're looking at your patients and trying to do the detective work to figure out how to treat the cause and not just the effect.
And so that seems kind of like an overwhelming list. And obviously, if you're working with a practitioner, they're going to help you kind of one by one or multiple things at one time work through that list. Any advice for somebody out there kind of trying to do this on their own and trying to sort through that list, some of the heavy hitters to get out of their life?
Yes, I think, again, this recurring theme, it comes back once again to almost the same things, and that is start clean, right? What we want to do is to take as much of the garbage out of our diet and lifestyle as is possible. And most of us somewhere intuitively know where those things reside. We might want to think, well, they really don't affect me. I mean, many other people are doing these things and they're okay, so I'd probably be okay too. But if you're not okay, then the rules of the road for you may not be the same rules of the road as somebody else. So that means you have to go the extra margin to start cleaning up your lifestyle, cleaning up your environment, cleaning up your diet. So staying away from processed foods, staying away from deep fat fried foods, staying away from high sugared foods because we know sugar can glycosylate and that produces these funny proteins. Staying away from deep, high fat fried and or barbecued foods because those forms these glycotoxins through the charring of meat and proteins. So, there's certain things that one can do fairly simply without becoming a fanatic. I mean, you can become so phobic about this that it can drive you crazy, obviously, because you don't want to touch any molecule that's foreign, and that then makes a person so stressed that maybe that is an immune inducer.
Right.
So we want to keep it in balance. But there are certain things, just cleaning up your diet, that can have an unbelievably positive effect. We've seen this in hundreds and hundreds of people over the last 20 years in the research that we've been doing in this area. And, it's very interesting that the docs that were in my research clinic for 11 years became very, very almost bullish about, because we did many clinical studies on different types of autoimmune diseases, and they became very bullish, saying, the name of the disease might be different, but the way we're going to approach it is the same. We're going to clean up that person's lifestyle, and we're going to get reproducible results. I don't care what they call the condition. What we know is that they suffer from similar origins, which is this adverse response of the immune system to a foreign environment.
And that's a great point. So, in speaking with that, and, in conventional medicine, it's very fractured. If you have rheumatoid arthritis, you're going to the rheumatologist. If you have thyroid disease, you're going to the endocrinologist, or diabetes. If you have Crohn's, you're going to the gastroenterologist. So, in speaking of that, why is it that it is so fractured, and they have all these different names, yet, as you mentioned, it's all being pretty much treated with the same types of drugs, these immunosuppressive drugs?
Well, I think your education was probably similar to mine, although I know I preceded you by a few decades, but
not decades, maybe a few years.
But I think that the theme was the same, and the theme was that we were instructed and trained and really reflexively conditioned to respond to the question of what is the diagnosis, and the more that you could become a skilled diagnostician, the more kudos you got as a student, and the more rewards you got, and the better recommendations you got, and the better performance. So there was a selection for diagnosticians. And what happens with diagnostics is if you're driving to get the name of the disease, I use a little term which I know is facetious, but it kind of describes the model, and that is more and more about less and less until you know everything about nothing. And so what happens is you start getting funneled down into a specific organ with a specific pathology that you can look at under the microscope or in histology or by some diagnostic technology, and you get rewarded for saying, wow, you picked that up. That's really good. Of the thousands of different diagnoses, you got the right diagnoses. But in so doing, you eliminate the forest for the trees, right? You've gotten down to looking for one tree, and you've determined the tree, but you've forgotten about the ecosystem in which the tree is living. How does that tree exist within the forest of all the other plants and animals that are living in that ecosystem? And so I think that this model that we're now emerging to, what we call systems biology, the 21st century kind of revision of medicine, is to say, the forest is as important, or maybe even in some cases more important than the tree. You can name the tree and know nothing about the forest. Maybe it's better to be an ecologist and know about the forest, and then you can figure out the trees later. And that's what I think has really happened in medicine, is that we got so tied up with getting precise about a diagnosis, and then that siloed us into these country club memberships that we call medical specialties. And each medical specialty has its own country club membership, its own language, its own vocabulary, its own diagnostic codes, and its own drugs. And they treat each organ separate from that of the other organs that are treated by their colleagues across the street. And that then prevents us from ever looking at the unified field theory of how did that person actually end up with that. Because a person that has an autoimmune disease, by the way, is probably also seeing a cardiologist because they're more likely to have heart disease, and they're probably seeing an orthopedist or an endocrinologist because they're likely to have osteoporosis. Those three diseases are called comorbids. They exist in the same person, and so often a person might have all three of those diseases, and they're seeing three subspecialists with three sets of drugs to treat three apparently different independent diseases when they're all interconnected to the same exact problem. You treat the cause. You don't need three doctors treating three different diseases. You need one informed diagnostic doctor who understands how they're interconnected and treats the effect and not the cause. And that's the functional medicine model.
Yeah, I mean, I as I was going through medical school, I actually went in knowing I would do something like functional medicine. I just didn't know the name or, how it existed or what I needed to do to get trained, but that was my inclination. And so I kind of questioned that, we're learning here today, we learned about the cardiovascular system, or this week we did, and the next week was the gastroenterology, the GI system. And at the time I thought, well, shouldn't there be something that puts it all together? But then I didn't really think about it. But now in retrospect, it's kind of like, how in the world do you go through medicine? Fine if you want to teach this systems-based approach of this is this system, but then there needs to be okay, now let's put it all together. And how do they all talk to each other? And literally, that never happens in medical school, at least when I was in medical school, and it wasn't that long ago. I mean, it's fascinating. I mean, of course, with us being on this side of the coin, right, it's like mind-blowing. But even if you're not on that side of the coin, it does seem a little odd. I mean, even to the average person, that there would never be that course to say, okay, and here's how they all talk.
Well, I obviously absolutely agree with you, and I think you said it beautifully, but let's ask where that concept came from. I think it came from the birthing of a medicine that everyone agreed was miraculous, and that was the birthing of antibiotics. When Alexander Fleming made these discoveries about the mold, and ultimately was defined as being this molecule called penicillin, and that you could treat a specific bug that was going to cause infection and death in a person with this molecule called penicillin, this mold metabolite, it then gave us the belief that all diseases somehow have their origin with one agent creating one disease for which one molecule or one drug could treat it. It was a wonderful model. I mean, wouldn't it be wonderful if all we had to do was memorize a list of one disease, one agent that causes it, and one drug? I mean, we could be so successful. But unfortunately, that model doesn't participate as the dominant cause of most of the chronic diseases. And by the way, that was a whole theme of my book, The Disease Delusion, to say you can't use the infectious disease model to try to understand the chronic disease model. They're entirely different etiologies. So infectious disease, one bug causes one disease for which one drug can treat it. And that was really a great linear model, and therefore you wanted to know what was that bug. If you could define that bug, gram-negative or gram-positive bacteria, then you could find the molecule and treat it. You were a wizard, and you would be considered the best doc on the block. But in a chronic illness, it's not that way. You're not going to find the one agent to cause the one disease for which one pill is going to treat it. So we need a different model. And this is the transition we're undergoing right now, because it's only within the last 20 years that the etiology or the origin of these chronic diseases started to be understood. When I was in medical school in the 60s, the late 60s, there was really no explanation at the mechanistic level of the origin of these chronic diseases. We could describe them, we understood them pathologically, but we didn't know where they came from. Since then to today, 40 years, unbelievable progress has been made in understanding their origin. And as we understand their origin, we understand it's not one agent against one disease for which one pill will treat it. You're never going to find the one pill to treat any one of these chronic diseases. You have to find the system to manage that patient's unique response to their environment. That's the new medicine.
I always tell my patients, yes, it's never, I had somebody actually literally yesterday asking me, well, I just wanted it to be this one thing. I said, it's never one thing. I said, unless you got in a car accident and you severed your arm off and you now have phantom pain, it's never one thing, short of an accident. Yep. I mean, even infections nowadays, can be the tipping point or the straw that broke the camel's back and unravels everything, as we've already talked about with the epigenetics. So I usually use the accident now. Well, slightly off topic, but not really. Let's just talk about, the impact of functional medicine and where it's going. There's going to be a clinic at the Cleveland Clinic with functional medicine. I mean, what is the state of sort of trying to change the medical system, either through, medical education or, even here in a, very well respected, large sort of typical mainstream institution like the Cleveland Clinic? You must be very proud.
Yeah, I'm really excited to watch how it's evolving, because I think we all recognize that in general, major cultural changes don't occur as a consequence of one movement, one organization, one person. There may be spearheading groups, or there may be an individual that's the lightning rod, but it requires a village to really create great change. And so it comes from multiple sources. And I think that's what I see right now converging is, as I travel around, and I still do quite a bit of traveling and talking to all sorts of different groups from the genomics area to the lifestyle medicine area to the chronic disease area to the diagnostic medicine area. As I travel around and talking to both scientists as well as clinicians, what I see is common concerns and common thoughts. I've had the privilege over the last year of meeting and interacting with a number of the CEOs of large big five pharma companies. And we might think of them as being maybe totally opposed to these concepts that we're discussing. But actually, it's a major topic of conversations that I've had with them or have been engaged in when they've been talking to other people. These thoughts that we're describing are on the minds and on the voices of people virtually in every sector of the healthcare community, from healthcare policymakers to healthcare finance individuals to innovators, researchers, clinicians, clinic managers, medical school presidents. I've met with 4 of the top medical schools and their presidents and had similar conversations. So I think that there is a convergent opportunity here for a major paradigm shift, to use a Thomas Kuhn statement, and or to use a Malcolm Gladwell. We're definitely getting close to a tipping point. And I think as a consequence, it will not be one thing that drives us over. It's not going to be just the Institute for Functional Medicine or the Cleveland Clinic or Leroy Hood's Institute for System Biology with their Pioneer 100 study that they're doing now to start looking at the trajectory towards chronic illness based upon the complex omics that people have, including their microbiome, their gut bacteria. It'll be a combination of all these factors. I was just talking actually with a guy that I think is one of the more brilliant people I've ever known. Eric Schott is his name, and he's was given a Carl Icahn fellowship. Actually, it was more than a fellowship. It was a sponsorship to set up a Institute of Translational Genomics at Einstein School of Medicine in New York, and so he got, I think, a $120 million grant, and so they put together this incredible institute there over the last couple of years, and his whole concept, having worked for Merck as a senior scientist there and done all sorts of remarkable things in the genomics field, he said that the more and more we learn, the more and more we recognize that it is diet, lifestyle, and environment that are the wild cards that ultimately trigger genes into the production of alarm that we call illness. And that the solution to this problem will be understanding in the individual what their genes will respond to, both in a positive and negative way, and designing individualized environments for them by personalized medicine. Well, that's been the theme that we've had in functional medicine since 1990 when we founded the Institute for Functional Medicine. So I think this is a movement that's greater than individuals. It is a movement of need. It's a compassionate move to reduce human suffering that is largely preventable. This is a global problem, as you probably know. We were so worried about the rising tide of type 2 diabetes and so forth in the United States, but it actually pales in comparison to what's going on in China, which I was recently visiting. And the epidemic nature of type 2 diabetes there is like an infectious disease. It's like AIDS in the 80s in the United States. It's just growing astronomically, and it's not a consequence of the genes of the Chinese people having suddenly changed. It's all these epigenetic things that are happening due to industrialization and the westernized lifestyle. So I think we have a tremendous opportunity to witness in our lives one of the most remarkable changes, comparable to what happened when sanitation, hygiene, and improved nutrition were introduced at the turn of the last century, and we increased mean average life expectancy by 20 years, in less than 20 years. That's what can happen.
Yeah. It'd be interesting to see, how ultimately the Cleveland Clinic responds, as people begin to get well and their patient base, gets well and moves on, and the doctors, there'll always be patients, and at least for the next years to come till we get out of this mess. But it will be interesting to see how a system like that functions within the broader system.
I absolutely agree. I think that that there have been obviously some concerns on the part of some that, gee whiz, they may lose their economic station as a consequence of these transitions. But my belief is, wouldn't it be wonderful to convert our economy from a disease care economy to a healthcare economy? It's not just health alone. Health in the broadest context is human potential movement. It's related to bringing the best out of people. It's people being able to do the things that they would want to do, but their ill health was preventing them from doing. When you start really talking about affirming health in individuals, you're talking about people gaining the best of life. And if we move from disease, which is a fear-based model, to health, which is an optimistic go-forward model, it's a cultural transformative opportunity. And I think that's what's going to occur. It's interesting right now that the most highly rewarded people in our system, in our quote healthcare system, are those that are the most specialized in disease care. Mm-hmm. Wouldn't it be nice if the most rewarded and highly esteemed people were those that were rewarded for healthcare? Wow, that's a unique concept. So I think that's where we're heading with these new technologies. It's a very, very remarkable period. And it's interesting to note, I interviewed James Fries for my Functional Medicine Update, which I've been doing now for going on 33 years every month. Actually quite proud of that. Haven't missed a month in 33 years.
Congratulations.
And, yes, it's pretty, just saying it's kind of like scary. But anyway, Dr. Fries, I interviewed in one of the first issues back when I started Functional Medicine Update, professor of medicine at Stanford, now emeritus. And he was the guy that wrote this landmark article in 1980 called Aging, Compression, Morbidity, and Natural Death, in which he talked about if we could only introduce proper personalized approaches towards lifestyle, that we could reduce the burden of chronic disease. And he then went on to do a study over 20 years with a colleague, Dr. Crapo, which they published in 1998 in the New England Journal of Medicine, showing that yes, in fact, that people that introduce these lifestyle principles would in fact have something like 11 years onset to the age of first infirmity. So my feeling is that this particular approach is a very, very interesting approach that really does, in fact, meet the threshold of truth. And when I talked just recently to Dr. Fries, who now, as I said, is an emeritus professor, I said, so James, exactly, how do you view all this? He said, well, it's interesting because he started off as the head of the Department of Rheumatology at Stanford, looking at this for the disability of his patients with autoimmune disease. And the drugs that they were using were kind of handling the pain, but they weren't improving their function. Their range of motion was still decreased, their ability to enjoy life was still compromised, and he said there has to be other approaches. And he said it was that led him as a rheumatologist, the head of the department at Stanford of rheumatology, into this whole construct of what we now would call functional medicine. In fact, I'm very proud that he was the first keynote speaker at the first IFM symposium we held at the Wailea Four Seasons Resort in 1991.
Wow.
He was our first speaker. So, these things go full circle. They go loops within loops, and I think that autoimmune disease, which is a rising condition in our society, is a direct manifestation of this mismatch between genes and environment, which is a solvable problem if we ask the right questions.
And when somebody goes to a doctor, since functional medicine still is not so mainstream, people may not have access. Many of us don't accept insurance because of the nature of the length of the time of appointments and whatnot. So what are some questions that patients can ask when they're going to their doctor to kind of assess their treatment approach, their willingness to consider diet and lifestyle? Are there anything that you could help guide a patient question-wise to assess, is this the right doctor for them?
Yes, I think that, and I know you know this, and your patients obviously already have that intuition. The most important question of all is my physician at all interested in how I live, in my story? Not just in my disease, but in my story. Because that story relates to eating, living, walking, breathing, drinking, interacting, loving, hating, all these various factors, occupation, environment, exposure to radiation, all those things. If they're not interested really in those, or they just give lip service to it, they don't really have the time for those things to really become an important part of the understanding of you as a patient, then you can probably come with a pretty high security that your doctor is very focused on disease and not focused on these things that we're talking about. Now, I'm not saying that makes them a bad doctor. I think some of the best doctors in the world that are dealing with traumatic care and emergency medicine are people who are totally focused on trying to understand the disease of the moment and save that patient's life. So there's a skill in that I think is very meritorious. But if you're talking about a trajectory going forward to try to ask, where did this come from? How do we get rid of a chronic condition, not an acute condition? It requires a different set of skills and a different set of questions to be asked. And I think the patient who says, well, my doctor never is interested in knowing any of those things, they don't have the time or it doesn't fit into their even requirement for the information, then I would say, okay, then you're probably pretty assured you're going to have a focus on disease, not a focus on health.
It's interesting that you say that. My training was in emergency medicine, and I worked as an emergency physician before I went into functional medicine. And honestly, one of my fears, I had two fears when I went into functional medicine. One was that people weren't going to get well, and I was going to have to, in emergency medicine, you hopefully never see the person again. So I was really concerned about that follow-up, and then if they weren't getting well, what was I going to do about that? And then two, I'm sort of like, what's the issue? Deal with it, move on. And I'm a very, very curious person by nature, so I knew I would like it, but I was concerned, was I going to be interested? And I could sit and talk to patients all day long. I wish I didn't have to do anything else, because I love people's stories. I get so fascinated by the story, but I didn't know that I would, because that wasn't how I was trained. So those were two skills that I think, obviously, naturally that I had, which made me curious and want to go into functional medicine, but they weren't skills that were honed in my training. So I was nervous about, was I going to be able to, hone those in, on my own. So I appreciate you making those distinctions.
Well, and I think that says something about you, and I don't want to be making you embarrassed, but I think that's a huge testament to you and the way that you approach life in your practice and in your profession is. Clearly there's a little bit of risk of stepping out of the lines and opening up new questions and getting into that discomfort of having to learn new skills. And often, we're not even reinforced for learning those new skills. People might even say, why the heck are you spending your time doing that? You ought to be doing this. And so you have to even go against the grain at times. So I think it takes a really remarkable person to do this. The number of hours you spend in gaining these new skills that were not in your curriculum, they probably weren't on your board exams. You didn't have to really do this. It wasn't a requirement.
Yeah.
It's a testament to the reason that people really, the purity of learning, right? And we're always in that process of, I know I can do better. I know that everything I've learned is great, but it's not enough. There's more to learn. And it takes a special person to make that dedication and that self-sacrifice. So on behalf of your patients, both past, present, and future, thank you. That's a big commitment.
Well, thank you. I appreciate it. I'm always in awe of people like yourself who, I have a personal story. Conventional medicine failed me. So that was sort of a driving force for me. It's always interesting to me that people who, I heard your personal story when we did a podcast prior, and you don't have a personal health story, so to speak. And so I am always in awe of those of you who dedicate your lives to, to helping the rest of us who do have these personal stories. And it's obviously because of you that I'm able to do what I do and help the people. So I thank you.
Well, thank you. I think that's the tribe I was speaking about. There are so many people with different skills and backgrounds and expertise that are are really starting to say, I can take what I've learned and I can do better with it by looking at a slightly different perspective and working in a slightly different way. And I think that is what transforms and refines society.
Well, as we wrap up, as we mentioned, not a lot of people have, access to functional medicine physicians, and we're trying to make the summit, something that people can have something valuable to leave with. And I know each topic and each speaker, they'll leave with some tips. But are there 3 to 5 things that you could recommend, that someone today suffering with autoimmunity, either to reverse or prevent autoimmune diseases, that they could start doing on their own, today?
Yeah, I think that there are 3 things that are probably right at the head of the list, and that is number one. I said, get away from processed foods and the fast food restaurants for a period of a couple of months, and see how that influences your health. That alone may open up all sorts of ahas. That's kind of step 1. Step 2 is this whole oils and fats story, and try to improve your omega-3 oil intake. Fatty fish like salmon and omega-3 oils. I know there's a lot of back and forth controversy about omega-3s right now, but I can tell you, if you weigh the studies going way back to Joel Krimmer, who was at New York Medical College and did the first studies on placebo-controlled trials in rheumatoid arthritis with fish oils and showing a very positive clinical benefit under controlled conditions, that I'm convinced that there's a very positive role with omega-3s in improving autoimmune inflammatory conditions. Number 3 on my list would be, I think that exercise therapy, or let's call it activity, not overdoing, but this use it or lose it. It's always ironic to me that people that have the greatest musculoskeletal and joint-related problems are the ones that have completely stopped any activity. And the things that we talk about with inflammation, there's a certain level of positiveness about inflammation that induces repair of tissues. If you completely sit quiet with no inflammation and you're like in casts, you put casts on all your joints, that's the case where you'll get the most joint degeneration. You need to keep moving, because a low level of your immune system activities, reforming and recycling old materials, is really important for reducing inflammation. It almost seems paradoxical that a small amount of inflammation induces anti-inflammation, but that's how it works. So you want to be in a proper physical conditioning program. I mean, clearly I'm not talking about preparing for running marathons or anything, but movement, massage, physical medicine, chiropractic, acupuncture, all these things can be very, very helpful in the structural component of these conditions, because structure and function are intimately tied together. I talk about that in chapter 11 of my book, that often we forget that function is structure and structure is function, so we need them to be tightly tied. So those would be 3 of the top things. I could go down the list, but maybe that's enough to keep people at least started down the road.
Absolutely. Well, thank you so much, Dr. Bland. It's been an honor and a pleasure to have you on, and thank you for sharing your time with us.
Well, Dr. Mars, I think you exemplify exactly where the new medicine is going, and how the doctors of our future are going to really create solutions to chronic illness, and the dedication that's required to do it. So thank you very, very much, and I just wish you the continued great success with you and your patients.
Thank you. I appreciate it. Take care.
You too. Bye-bye.
Bye.